for the kind invitation for this meeting, which is I guess mainly for the residents, nephrology, DNB residents. So the purpose of this class is to make you all understand about the basic concepts in radiology as applicable to clinical nephrology, the evaluation of the kidneys and the urinary system. As a nephrology resident, you need to be aware about the basic overview, basic points, what you need to expect from imaging modalities, from CT, from MRI, from ultrasound and X-rays. And you also need to be aware about the basics of image interpretation as well, as it may help you in day-to-day clinical practice. So the spectrum of radiology for nephrology extends right from urinary calculus disease to congenital developmental lesions to infection, inflammatory conditions, evaluation of the renal tumors, renal vascular diseases, transplant evaluation, and miscellaneous settings. So I will go through these clinical settings gradually as we proceed, but initially a brief overview about how to approach an abdominal radiograph, as you will see it quite commonly as a nephrology resident. So in an abdominal radiograph, you are particularly interested in the KUV region. So this is the L1, L2, and L3 vertebrae, and this is the right renal margin, and this is the left renal opacity. The margins of the kidneys can be seen in most of the radiographs, depending upon the amount of fat in the retroperitoneum. If there is paucity of fat, then the margins will not be very well seen, and accordingly, you will be able to look at the size of the kidney, whether it is small or large or normal size. So normally it should be around 3, it should not be more than 3 vertebral body height. So here you can see the right renal outline, and it is just slightly approximately around 3 vertebral height, so which is all right. And similarly on the left side, where the margins are less well defined as compared to right side. Similarly, chest radiograph is very important for nephrologists because of the common complications in CKD, ranging from pulmonary edema to fungal infections and other lesions in the lungs. So it is important for nephrology resident to at least pick up the abnormality, compare the apex from 2 sides, compare the upper zones, compare the middle zones, compare the lower zones on both sides. Normally in a standing erect radiograph, the vascular markings, this is the pulmonary artery lower lobe on right side, left side. So vascular marking should be more prominent in the lower zones on both sides and less prominent in the upper zones because of the gravitational effect in the dependent part. But in patients with pulmonary edema, you can expect cephalization and more flow or same degree of vascular markings can be seen in the upper part as well as in the lower part, which is an important sign of pulmonary edema, which can be seen with CKD. Similarly, you can see the right renal margin, the left renal margin, then the psoas margins on both sides. You can see the calculus in the lower. This is the left renal outline, which can be seen. Again, it is not significantly not larger than 3 vertebral body. So this is normal sized kidney, and you can see a stone in the lower polar region of the left kidney. So when it comes to stones, the CT is the modality of choice, and we can exactly see and pinpoint the stone in the renal calycial system, the ureter, and in the urinary bladder. We can exactly localize the stone, measure the distance from different coordinates along the lateral body wall, the posterior body wall, and accordingly decide the feasibility for lithotripsy if it is required. Similarly, the density measurement also helps in deciding whether the stone is feasible for lithotripsy or not, depending upon the Hounsfield values. Whenever there is a stone in the ureter, it is important to carefully look at the ureteric wall. If the ureteric wall is not thick or not inflamed, then the chances of its spontaneous passage are quite high. But here you can see there is thickening of the ureteric wall. There is significant inflammatory changes in the left kidney. So this suggests that the ureteric stone is quite likely to be impacted in this case. So the ureteric or the renal stones can be better evaluated with the dual energy CT or dual source CT. Here you can see the better stone composition with help of dual energy CT as compared to the routine CT scanners. An approach to IVP is very important, as we can see the films, the renal film, the ureter is seen, and the bladder film. So in the initial 2 minutes to 3 minutes film, we can only see the nephrographic phase. Only the renal outline is seen because the contrast is seen in the cortex and medulla. But after the 5 and 10 minutes film, we can see the excretion of the contrast into the urinary, into calyceal system, and this is what is called as pylographic phase. So this is the film in pylographic phase when contrast is seen in the urinary system, the calyceal system on both sides, with optimal opacification of the ureters on both sides, and gradually the bladder can be seen as completely filled area. So it is important to look at the appearance of the calyceal system. As we can see here, the normal C-shaped appearance of the calyx is normal. This is the minor calyx, this is the major calyx, and this is the pelvic calyx, renal pelvis, this is the PU junction, and this is the ureter. So this is the normal appearance. And here is the example where you can see the distortion, significant distortion. There is extrinsic compression of the over the pelvic system, distortion, and there is widening of the distance between the two kidneys. So this is either because of aortic aneurysm or a lymph nodal mass. Only two conditions are possible, and in this example, this was because of the enlarged lymph nodes which is displacing the ureters and the kidneys. This is another example where the distance between the two ureter is quite reduced, and here there is medialization. So as from the pelvic ureteric junction, as the ureter descends, it should follow the transverse process of vertebra on both sides. So at L4 level, in this case, you can see it is unduly medial. It should normally overlie the follow the transverse process and then sacral LR like this, but here it is quite medial, is almost close to the paramedian location because of the retroperitoneal fibrosis. The same pattern, after the contrast is injected, the contrast follows a particular path, and accordingly we can divide the phases into different phases in IVP as well as in CT urography. In IVP, you have usually two phases because of the resolution difference, nephrographic phase, and when the contrast comes into pylographic phase, or the pylographic phase. While CT, you are in a position to differentiate contrast, which is predominantly in the cortex as compared to in the medulla. So we can see the corticomedullary phase here. And then we can see the nephrographic phase here, where the corticomedullary differentiation is relatively less. So this is the first phase on CT urography, corticomedullary phase, then the nephrographic phase, and then the pylographic phase when the contrast is seen in the pelvic calyceal system. So this is the image. This is the conventional full film pylographic phase, where we can see the renal pelvis, ureter, and the bladder in a single image. The same is possible to much better extent on a CT urography. So this is a CT urography image on the right side. This is modification of CT urography, where the contrast is given in two different phases. Just a minute. Sorry, just a minute. So this is a modification of the CT urography, where you can see the contrast in the vascular system as well as the contrast in the pylographic system. So this is a protocol where we divide the contrast into two phases, the biphasic protocol, this is called, and the contrast which is injected early is already seen in the pelvic calyceal system and delineates the ureter and the bladder, while the contrast which is injected later on is still seen in the arterial system, as we can see in this image. So then filling defects on IEP should be picked up. As we can see, this is the normal C-shaped appearance of the calyx. So this is normal, while here you can see the abnormality, and here you can see the focal filling defect because of the urinary and because of the calculus in the calyceal system. You can see the on ultrasound, the calyx stones can be seen as a echogenic area, and there is a shadowing just distal to this. So this is important that this kind of echogenicity can be seen because of the vascular interfaces also on ultrasound, which can be falsely labeled as calculus. So therefore, it is important to be sure that there is a shadowing distal to this, and then only it should be labeled as stone. Another way is to look for this Doppler signal just distal to the stone, which is a mixing of color, which is because of the artifact. And this is a very important sign to ensure that this is a actual calculus and is not a echogenic interface. This is a stipple sign here. We can see the irregular margins of a focal lesion in the urinary bladder because of the transitional cell carcinoma. This is a IVP film. Here, the right kidney, the left kidney. On the left side, you can see the contrast is already seen in the urinary pelvic calyceal system on the left side. While on the right side, we can see the contrast is not exceeded in the urinary system and is still in the nephrographic phase. So this is called an appearance called dense persistent nephrogram on the right side, which is an abnormality and is usually suggests distal ureteric obstruction, dense persistent nephrogram. So here we can, another important point is the ureter should usually, because of the ureteric peristalsis, you should not be able to see the ureter in continuity on in a normal condition. But here you can see the continuous column of the ureter. So this is usually called standing column of ureter and is usually because of a distal obstruction. So this is a normal left kidney. Here you can see the drooping lily appearance of the kidney on the right side because of the duplex moiety on the right side. So you are all aware about the Wiegand's-Meyer law, which determines which moiety is in the lower part, which moiety is in the upper part. The cobra head appearance is because of the edema surrounding the ureterocele, which is seen and as a filling defect in the urinary bladder, as we can see here in this case. So this is what I already mentioned, medial coursing of the ureter because of the median waist. So this is unduly medial deviation of the ureter because of the RPF in this example. If this medialization is only seen on the right side, then it is usually called because of the retrocaval ureter, as we can see the IVC, and this is the ureter, and ureter is posterior to the IVC because of the anomaly of the IVC, and which leads to posterior location of the ureter, proximal dilatation only on right side. This is retrocaval ureter. Then, as you are already aware about this normal C appearance of the calyceal system, this is normal, but at times you can see this punctate appearance. Look at this punctate appearance because of this abnormality in the calyceal cup, which is called paintbrush appearance. Paintbrush appearance, or also called bucket of flower appearance. This is because of the condition called medullary sponge kidney, which is a calyceal abnormality, a developmental abnormality. This is another IVP image where we can see the extrinsic impression over the calyceal system on both sides because of the multiple mass effect, extrinsic mass effect, because in a patient with polycystic kidney where cysts are causing extrinsic effect and is leading to appearance called spider leg appearance. Here we can see the right kidney is normal on the CT scan, while the left kidney is enlarged and edematous, and we can see area of hypodense attenuation, and then fluid is seen. There are inflammatory changes in the left perinephric region, and because of the pyelonephritis and focal abscess formation in the left kidney. This is IEP image. You can see the left kidney is normal, but the right kidney shows focal stricture in the upper major calyx, and therefore this is because of the leading to focal calyceal dilatation in a patient with tubercular kidney on the right side. The same patient after some time with chronicity can lead to calcification of the right kidney. This is called putty kidney. Here again, another example, we can see the pyelonephritis, areas of abscess in the right kidney with formation of the right renal vein thrombosis. Another CT urography image, we can see the loss of normal calyceal cup. The calyceal cups are completely lost. Weird abnormal shapes are seen along the calyces because of the renal papillary necrosis, which can have varying shapes like as shown in this image. Then CT scan is very useful to pick up cyst and the lesions, cystic neoplasms. So whenever the lesion shows the straight margins with angular interface, it is most likely a benign cyst. If it is rounded with angular interface, it is benign. If it is rounded interface, then it is usually a malignancy or a cystic neoplasm. Here we can see a focal mass lesion in the kidney on the right side, calyceal dilatation, obstruction, and then we can see the tumor thrombosis. So this is the mass, this is the tumor thrombus in the IVC because of the extension of the lesion into the IVC. Now, how to differentiate TCC from RCC? It is very important to look at the morphology of the lesion. So as here we can see the RCC shows rounded or the ball morphology, which suggests RCC. Here is a tumor which doesn't cause distortion of the kidney, while the reniform shape, the bean shape of the kidney is preserved. So this is because of the TCC. CT is also useful in predicting the histological variety of the tumor. We can see the clear cell carcinoma shows significant enhancement as compared to aorta. So if it is beyond more than a particular ratio as compared to the aorta, it can help in diagnosing clear cell carcinoma. While if the tumor is to aorta attenuation ratio is less than 0.25, or that means the tumor is hypoenhancing, then it can be labeled as a non-clear cell variety of RCC. So depending upon the degree of enhancement and as compared to the tumor versus aortic enhancement ratio, we are in a position to diagnose clear cell from non-clear cell variety. Different post-processing protocols are available on CT, which are called MIP or VIT. So as a nephrology resident, you need to be aware about this. MIP is a maximum intensity projection which helps in picking up finer intrarenal branches. So MIP is useful for branching pattern, as we can see the finer branches much better on MIP image, while VRT is a volume rendering image which helps provides 3D rendered appearance of the renal vasculature and is useful for delineation of the complex venous anatomy, as we can see in this image. Right kidney can be seen in this image in this curved MPR or curved plane dedicated for the right kidney. Similarly, this is curved MPR, and this is another MPR which is designed according to the renal vessels for the left kidney. And this is a curved MPR. You can see the curved MPR, and you can see a single image which is showing the aorta, the renal artery, the right side, the left renal artery in a single image. So it is important to understand the contrast safety in CT and MRI. EGFR is very important to be calculated before giving CT or MRI contrast. If the EGFR is more than 60, then there is negligible risk. If it is less than 30, there is high risk of contrast induced nephropathy or iodinated contrast media. with the CT contrast and nephrogenic systemic fibrosis with gadolinium-based agents. So this is a uniform standardization, and this eGFR is therefore important to decide whether we can safely give the contrast or no. As a nephrology resident, you need to be very clear about this important point, that if KFT is abnormal, then CT and MRI contrast cannot be given to these patients, and only plain scans are possible. If there is a need for contrast flow dynamics, then contrast enhanced ultrasound is possible, because it is not affected by poor renal excretion, as this is mainly excreted through the lungs, because it is a bubble based contrast. This needs dedicated software and specific software for on the ultrasound system. Different indications include intravascular evaluation, intracavitary evaluation, and there are few contraindications, but usually it is a very good modality in patients where KFT is deranged. So this is an example of a pre-contrast kidney on right side. This is the cortical phase image, and this is a medullary phase image using a contrast enhanced ultrasound. So this is an example of a Bosniak category 2 lesion, where you can see the pre-contrast appearance of a cystic lesion, and then this is a post-contrast evaluation which hardly shows any mural enhancement, septations or any enhancing notice. Only some mural enhancement was seen. This is another example of a Bosniak category 3 lesion, where you can see the significant enhancement along the wall, along the septation inside the cystic lesion. So this is an important information to decide the Bosniak category of a cystic lesion with use of this contrast, which is absolutely safe despite abnormal creatinine values. So you can, this is another example, and we can see a cystic lesion with peripheral enhancement, which is a pseudocapsule in a patient with RCC. So this is contrast enhanced ultrasound, where cystic RCC or cystic lesions can be picked up very well without need for any iodinated contrast, which is not safe. Similarly, in patient with focal liver lesions, we can see the performance is almost matching with the corresponding CT images. You can see the plain scan, plain CT. This is the arterial phase scan, arterial phase CT. You can see enhancement, you can see enhancement. This is the venous phase washout is seen, and you can see the washout in the ultrasound image also. Apart from that, another important modality which you should be aware is a non-contrast enhanced MR angiography. So CT always require contrast for angiography, but MRI angiography can still be performed without the need for contrast, and is particularly useful in patients with CKD. And this is the example where this angiography is performed for right kidney and the left kidney. The aorta is nicely seen, and this is all without injection of any contrast, and this is a capability of MRI to acquire images without giving any contrast. The only limitation is the poor delineation of the finer intrarenal branches. But MRI has an important limitation. It is not good for evaluation of the stent. As we can see, this is the area of stent in the right renal artery in the proximal part, and is seen as a flow void despite the fact that the stent is patent. So MRI is not good for stent evaluation. So these are all, let's skip this thing. So this is an example by how to evaluate the stent. So this is the stent on the right side. This is the stent on the right side. DSA can show the vascular patency of the stent and the vessel, but CT angiography is very useful, and CT angiography can show the vessel and the surrounding structures in the same sitting. So CT angiography is a modality of choice when it comes to evaluation of the stent. So this is the right renal artery stent. You can see the stenosis in the distal part. We can cut across the stent, and we can see the in-stent stenosis in this stent on the right side, which is causing mild stenosis. So radiology plays an important role in renal transplant for pre-transplant workup, for donor evaluation, for recipient evaluation, for immediate post-transplant baseline, and early and late post-transplant studies. For transplant recipient, we can see the volume of the polycystic kidneys, if how much space is available in the iliac fossa for the transplant kidney can be assessed, and most importantly, it is important to carefully evaluate the aorta and the iliac arteries, the common iliac, the external iliac, and the internal iliac for the degree of atherosclerosis, because this is the arteries. These are the arteries where the transplant kidney will be anastomosed. So this should have minimal or no atherosclerosis. If they are heavily atherosclerotic, then the anastomotic site becomes difficult during the surgery. The basic concepts are all known to you. CT angiography is a modality of choice, particularly in open as well as donor laparoscopic donor nephrectomy, because in laparoscopic donor nephrectomy, the anatomical details should be known in much greater detail because of the limited surgical window. And second thing is it decides the fitness to donate. Like this is the example of how CT can help. CT can exactly delineate the renal vascular pedicle, the renal vein, the renal artery, and its major tributaries, the gonadal veins, the adrenal veins. So we can see the exact number of arteries on the right side, number of arteries on the right side, the accessory arteries, and the number of arteries on the left side, the number of renal veins, the duplication, and the area of bifurcation. If it is early bifurcation, then it becomes a problem during the surgical procedure. So renal allograft can be nicely evaluated based on the B mode ultrasound, color Doppler, and spectral Doppler. This is the first line imaging modality for renal allograft evaluation, followed by CT and MRI in select cases, or other modalities depending upon the findings on B mode ultrasound. So the most common complication is a peri-transplant collection, which can be seroma, lymph, bleed, or urine. As we can see in this example, this is a peri-transplant collection, and we can see the contrast is seen to extravasate in the delayed phase. So this is because of the urinoma formation in this case. This is another example. The patient had anuria at 1 week following the biopsy. Transplant biopsy was normal. So this is the transplant kidney. The biopsy was normal. This is the proximal stent. The distal end, the end of the stent is not seen in the bladder, rather it is floating freely in the peritoneal cavity. This is because of the distal ureteric slippage, because of the ischemic changes, and therefore the urinary bladder is completely empty as seen here. Urologic complications in renal transplant can include thickening of the urothelium. You can see the edema, the thickening of the wall of the renal pelvis, the ureter, and kinking and tethering at the anastomotic site with the urinary bladder. So this is ureteric stricture formation. Vascular complications in renal transplant are very important. So Doppler is a very useful modality. You can see this is the renal artery flow pattern. The renal artery flow, this is the baseline, and the flow should always be towards the positive side throughout the systole and even in the diastole. So this is the systole, the flow is forward, this is all right. But in the diastole, you need to see the flow in this part on the positive side. So here in this example, the flow is going towards the negative side. So this is a flow reversal in the diastole, which is a sign of renal venous thrombosis. So this is an important sign: enlarged edematous kidney, filling defect, non-opacification of the veins, and filling reversal of the diastolic flow in the renal artery, which is a sign of renal vein thrombosis. Then we can see the anastomotic site pseudoaneurysm, as we can see here in this example, and then we can see contrast opacification on CT angiography in the same case with pseudoaneurysm at the anastomotic site. We can see the pseudoaneurysm in this another example where ultrasound detected this aneurysm at the anastomotic site, and then MRI showed this aneurysm with peripheral thrombosis. Contrast cannot be given because KFT was borderline. So this was non-contrast MR angiography, and we can see the contrast and we can see the pseudoaneurysm and the neck of the pseudoaneurysm without giving any contrast using the non-contrast MR angiography protocol. Infections are very commonly seen in transplant, which should be picked up by imaging modalities. Here is a focal filling defect in a dilated renal pelvis. It is highly echogenic but weakly shadowing. There is no shadowing, and this is a hallmark of a fungal ball. This is a contrast injected in a transplant kidney with irregular margins, calcial dilatation, and irregularity because of tuberculosis. This is another example. We can see the kidney usually should show the hilum as a normal structure, but here the transplant kidney is not showing the hilum. The fat is all effaced. It is all dark kidney with uniform enhancement on CT. The hilum is not seen. The vessels are all displaced and encased, and this is because of the PTLD or the lymphoma of the post-transplant kidney in this case. While the above images are showing a focal lesion at the anastomotic site with the ureter, and this is because of the squamous cell carcinoma at the bladder ureteric junction. Small vessel ischemic processes include polyarteritis nodosa, as we can see abnormal enhancement of the kidney on both sides on CT angiography, and this is an important sign of polyarteritis nodosa, which is a small vessel vasculitis of the kidneys. We can, on CT, we can diagnose large vessels complication, which can lead to deranged renal perfusion. We can see the intimal dissection in the aorta. We can see the intimal dissection, intimal flap is seen, and then because of the poor pressure head, there is renal perfusion. We can see the ischemic nephropathy, thinning of the renal cortex, and abnormal enhancement of the renal parenchyma. This is another example. We can see the right kidney shows normal perfusion, normal enhancement, while the left kidney shows embolic occlusion, because we can see the filling defect in the left renal artery, and the left kidney is all small and shrunken. Similarly, popliteal arteries also shows occlusion. This is another example where we can see aortic aneurysm, large aortic aneurysm, but at the same time we can see the renal arteries are showing small intrarenal aneurysms on both sides, which can be nicely picked up on CT angiography. Aortoarteritis, we can see the multiple renal arteries on right side, multiple renal arteries, 3 on the right side, 2 on the left side, and the upper renal arteries are all small and shows proximal narrowing. Even the distal part is thick walled, the wall is thickened, and therefore you can see the upper pole of kidneys on both sides shows atrophic changes because of the aortoarteritis, which is involving the aorta and the upper and middle renal arteries on both sides, leading to ischemic nephropathy, mainly in the upper pole. Fibromuscular dysplasia is normally we see the kidney renal artery as a smooth structure like this, but this is a beaded appearance. The beaded appearance is because of the fibromuscular dysplasia, which is involving the mid and distal part of the renal artery. Valuated junction obstruction can be seen here as abrupt constriction at the PU junction with crossing vessel, which is in fact causing indentation over the pelvic junction. So this is PU junction obstruction can be seen if there is any vascular cause which is leading to obstruction, can be nicely diagnosed on CT angiography. Common complications in CKD patients include pulmonary edema. As I mentioned, you can see more vessels in the upper part, almost same as the lower lobe. Then we can see focal lesions, focal fluid in the major and minor fissure on the right side. These are the focal fluid. These are pseudo tumors. These are not true tumors. These are pseudo tumors in the minor and major fissure. This is loculated fluid which can be seen, and then this is we can see the smooth interstitial thickening because of the pulmonary edema on both sides. Pneumocystis infection, pneumocystis xerovecii or CMV infection can be seen as ground glass appearance on these images, and while this is a pneumocystis carinii infection where we can see lower lobe predisposition, perivascular cystic areas with interstitial thickening in the lower lobes. Fungal infection is classically seen as the focal cavitary lesion with surrounding ground glass haze, or CT halo sign is a hallmark of fungal infection in the lungs. This tree in bud appearance, you can see multiple nodules which looks like a tree in a bud appearance. This is because of the tubercular bronchiolitis in the lungs. This is again an important complication in a CKD or a post-transplant patient. COVID-19 pneumonitis is also commonly seen with CKD as we have seen recently in last few 1 or 2 years, multiple peripheral ground glass opacities as seen on this both sides in the peripheral distribution, or with increase it can give a picture of ARDS as we can see in this image. Brain infarcts are common complications as we can see this diffusion weighted images shows bright signal which is dark on ADC images because of the acute embolic infarct, while fungal abscesses can be seen as ring enhancing lesions with significant edema as we can see in this image are also commonly seen. Press or posterior reversible encephalopathy syndrome is an important complication in a renal transplant. Here we can see abnormalities or focal areas of abnormal signal intensity mainly in the peripheral parieto-occipital regions on both sides, and there is no abnormality on diffusion weighted images because this is a reversible ischemia. This is not complete ischemia, so this is also completely reversible and has a good prognosis and is because of the hemodynamic imbalance. And in renal transplant, it is usually late onset with hypertension, and usually there is less brain edema. So this is a reversible process and is usually seen in CKD patients or in with post-transplant settings, press or posterior reversible encephalopathy syndrome. Then as a nephrology resident, you are aware about the progression of CKD, the stages of CKD, the clinical and laboratory parameters to diagnose and work up the patient of chronic kidney disease. But what I am going to emphasize is the new imaging modalities, including functional MR studies, which is now coming up in a big way. And there are a lot of literature, a lot of articles to address functional MR studies. So this is the pathophysiology of chronic kidney disease. Chronic medullary hypoxia leads to loss of peritubular capillaries, which in turn lead to interstitial hypoxia and lead to local inflammation and fibrosis. So these different components of CKD or different components of tissue hypoxia in a chronic kidney disease has a one important central feature, that is tissue oxygenation. This tissue oxygenation leads to interstitial hypoxia, which can be picked up with cold MRI technique, while local inflammation and fibrosis can be picked up with diffusion weighted imaging and diffusion tensor imaging, and loss of peritubular capillaries can be picked up with renography. So these are different sequences. Like this is a bold MRI in transplant kidney, which does not require any contrast, and is a imaging modality, is a MRI tool which can help in picking up abnormality at a quite early stage in patients with CKD. So these are the ROI values measured in cortex and the medulla, and depending, so this is still work in progress, and there are different set of cutoff values which are described in normal and abnormal kidneys. Like the different acquisition methods are described, as we can see the measure the ROI values, or otherwise we can see the color coding maps of the hypoxia in the different part of the cortex and the medulla. So this was the study we have done, and we have found significant R2 star values between the normal and the acute dysfunction group and the chronic dysfunction group. So what I mean to convey that bold MRI is an important component of functional MR studies, which is now coming up in a big way and is likely to evolve further. Right now, the closest non-invasive imaging option to diagnose CKD or to prognosticate the progression of CKD is color Doppler based RI values, but RI values have significant overlap and lot of gray zones are there. So therefore, functional MRI method, particularly bold MRI, is a very important tool which is coming up in a big way for non-invasive diagnosis of transplant dysfunction, to decide the need for allograft biopsy. It is tool to evaluate the progression of CKD. It can prognosticate the renal functions. It can predict end-stage kidney in these patients, and it helps in supporting the drug trials to decide the efficacy of potential nephroprotective drugs. So these are the wide range of roles this is going to play. Another important upcoming modality in functional MRI is diffusion tensor MRI. So you can see this is the images we have acquired in our hospital itself, and this is from the internet. So we can see that because of the particular flow directionality of the urine in the nephrons, we can generate this directional component of the diffusion tensor imaging, as we can see here. And this this directional component, if it is normal, it suggests a normal kidney, while here any area of abnormality will start with disruption of this flow directionality of the nephrons. So this diffusion tensor, again, MRI is a very potent tool which can diagnose early CKD much before things manifest in creatinine values, or even before it manifests in RI values. So this is an example of a normal allograft where we can see the exactly perfect flow directionality in the nephrons of the kidney. While in a severe dysfunction, you can see the gross distortion of the directional component of the nephrons in the kidney. So this is what is called multiparametric functional MRI of the kidney, which includes structural MRI of basic T1 and T2 values, then bold MRI for tissue oxygenation, diffusion-weighted MRI, diffusion tensor MRI for microstructural details and interstitial fibrosis, and renography and phase contrast for the perfusion of the renal parenchyma. So as a nephrology resident, you need to be aware about this upcoming thing in imaging of the kidneys. Few radiology spotters, you can see the putty kidney on the right side, the left kidney is normal. You can see the CT scan, the Doppler on the right kidney, the left kidney. This is the milk of calcium cyst. You can see the milk of calcium cyst with fluid level, and this is the you can see the fluid level. But the contrast, once the contrast extends into the cyst, it is a calaceal diverticulum. Otherwise, it will be labeled as a milk of calcium cyst. On the left side, you can see the pyelonephritis, and the focal area of non-enhancement is because of the renal abscess on the left side. This is a IVP full length image where you can see the urinary bladder, you can see the kidneys on both sides, and you can see the outline of the kidneys, but the lower part of the outline is not very clearly seen, and rather we can see the lower poles of right and left kidney are close to each other because of the horseshoe appearance of this kidney. And therefore, the ureters are also quite close to the midline. So this is another example where we can see the horseshoe kidney. Both the renal parenchyma are fused, and apart from that, there are multiple cystic lesions, cysts in bilateral kidneys with variable sizes. And then you can see the similar cystic changes in the liver also. So this is a polycystic horseshoe kidney, which is in fact a double two entities in a single patient. This is polycystic as well as horseshoe kidney. This is another example of IVP image. This is for interpretation, and we can see the abnormal bladder shape. This is pear-shaped bladder. Surrounding area is dark while surrounding area is bright. So this is because of the pelvic fibrolipomatosis, pear-shaped bladder, while this is because of the pelvic hematoma. This is another important entity which should be known to nephrologists also. This is pelvic fibromatosis. Pelvic fat is all inflamed. The bladder is all deformed. Flame-shaped elongated bladder, which can lead to hydronephrosis on both sides, hydroureter on both sides, as we can see in these images. This is important to understand that in a small shrunken kidney, as we can see here, there can patient is on follow-up, and we can see a focal nodular lesion on both sides, multiple focal lesions which remains same or unchanged over years. These are typically focal segmental hypertrophy, which is commonly seen in patients with CKD, as we can see in these images. And very importantly, you can see the focal nodular lesions shows prominent enhancement, prominent vascularity, and does not show restricted diffusion on MRI to differentiate them from RCC. So this kind of focal nodular lesions in CKD are common findings. They should not be confused for RCC, and these are focal segmental hypertrophy in these patients. As I told previously, this is the right kidney, this is the right renal hilum, this is plain scan, this is contrast scan, this is normal. On the left side, we don't see the hilum, there is abnormal lesion here which is filling the hilum. So this is a faceless kidney. Once there is faceless kidney, it can be because of TCC of the kidney, or it can be because of the lymphoma of the kidney. Then again, very important cause of intermittent hematuria, particularly in patients who are lean and thin, particularly in early age in the teens. So this is a patient who is 15 years and there is focal dilatation of the left renal vein in the lateral segment. In the medial segment between the aorta and SMA, there is focal constriction. So this is typically called nutcracker syndrome or left renal vein hypertension. So there is, because of this constriction, it leads to, because of the paucity of fat here, this is a vascular compression syndrome. There is increase in the pressure in the lateral part, which transmits into the renal pelvic system and lead to intermittent hematuria. So this is a very important vascular cause of hematuria, particularly seen on left side. And these patients tend to improve significantly after the weight gain because the compression is relieved. Otherwise, surgical treatment is the only option. This is an example of IEP where we can see again the medialization of the ureter on both sides because of the median waist appearance, because of the retroperitoneal fibrosis and the encased ureter on both sides. This is a moth. This is a IEP image, and the nephrogram should be all uniform from upper pole to lower pole. But here we can see the significant areas of heterogeneity in the nephrogram because of the moth-eaten appearance. This is hallmark of small vessel vasculitis because it can lead to areas of ischemia and areas of normal appearance along with intrarenal aneurysms as seen in this DSA image. This is bilateral involvement. The striated and the appearance of nephrogram is quite heterogeneous and gives striated appearance. As we can see here is the striated appearance. This striated appearance is called striated nephrogram, where the most important differentials include distal obstruction or acute pyelonephritis or acute renal vein thrombosis. So these are the common differentials in this case. Otherwise, if it is bilateral, then AR-PKD is also an important differential for striated nephrogram. This is okay. So this is a appearance of multiple areas of thickening of the interstitium along with perihilar opacities on both sides because of the pulmonary edema on both sides. We can also see the peripheral interstitial thickness or curly B lines on both sides, which is because of the interstitial thickening. So again, we can see the CT appearance of pulmonary edema as we previously discussed, and this is the bat wing appearance, particularly seen in patients of CKD when pulmonary edema is seen of renal origin. This example shows multiple nodular lesions on both sides. These lesions are variable sized. Whenever the nodule, the lungs metastasis goes to lung, they preferentially goes to lower lobes. So lower lobe predominance is a sign of lesion which is coming through the hematogenous route. And if the lesions are variable in size, few nodules are small, few are large, there is range of sizes, then it is more likely to be metastatic. If the lesions are all similar sized, then it is more likely to be infective. So this is important. And whenever the nodules are, few nodules are seen on X-rays, few nodules are seen on CT, the best modality is a MIP image. MIP image is a will ensure that the nodules are seen much better. So MIP is a better way of looking at the nodules. The maximum intensity projection can show the nodules much better way as compared to routine CT films which are usually provided to the patients. This is an example of again the normal left kidney, the dense persistent nephrogram on the right kidney, which suggests that there is possibly a stone in the ureter, distal obstruction is there, and we can see the track the course of the ureter. This is all right, this is all right, and as we go below, there is a ureteric stone in this part. So this is causing this dense persistent nephrogram on the right side. This is an example of a MRI image. We can see the pregnancy is seen in this patient. The right kidney is normal and the maternal left kidney shows abnormal signal intensity, loss of corticomedullary differentiation surrounding edema is seen because of the pyelonephritis in the left kidney. This is another example. You can see the pyelonephritis on the right side. So always look at the perinephric fat. So this is the left kidney, which is the perinephric fat is almost all normal with dark appearance. While on the right side, you can see the kidney is completely enlarged as compared to left side. So enlarged edematous kidneys, and as compared to left side, you can see the fat is quite thick and edematous trending is seen. You can see the normally the perinephric facial planes are seen as thin, very poorly defined white lines, but here they are significantly thickened because of the inflammation. Again, we can see the focal filling defect in this part of the dilated renal pelvis because of the fungal ball. The same thing can be seen on the CT urography image where the contrast is filling the pelvis and we can see the fungal ball in the right kidney. This is again another example. The left kidney is normal. We can see the vascular calcification in the kidneys. The left perinephric fat is normal, but on the right side we can see the vascular calcification is there, but there is a obstructive calculus in the left right pelvic junction, right renal pelvis, and therefore there is enlargement of the right kidney with inflammatory changes, pyelonephritis, and then air foci are seen. So presence of air suggests emphysematous pyelonephritis. So it is important to understand that at times if the patient is sent to ultrasound and patient is quite sick and ultrasound is not showing the kidneys at all, or there is this kind of image where there is echogenic line and the kidneys are poorly defined, there is kidneys poorly defined and the details are very poorly localized and the patient is quite sick, then always suspect some form of condition which where there is emphysema, because whenever there is air in the kidney or anterior to the kidneys will be very poorly visualized on ultrasound. So this is maybe because of emphysematous pyelonephritis or something called as acute cortical necrosis. So this is another example where we see loss of corticomedullary differentiation, and then there is peripheral rim of capsular enhancement in the contrast, while the cortical region shows non-enhancement and only a thin rim of enhancement in the medullary region. So this is because of acute cortical necrosis, which led to this kind of appearance and echogenic area in the cortical region and poor delineation of the kidney on ultrasound. So always suspect emphysematous pyelonephritis or cortical necrosis, because whenever there is air in the cortex or in the perinephric region, the visualization of the kidney will be very, very poor. So to summarize, there are a wide range of clinical applications in nephrology there when it comes to radiology in nephrology practice, right from stones, congenital developmental lesions, infections, inflammations, pre or post transplant imaging of the renal tumors, vascular diseases, transplant workup, and wide range of miscellaneous conditions, including autoimmune diseases. So I know this is quite an overview of the spectrum of radiology, what you need to know. But you, as a nephrology resident, you need to know a broad overview about the radiology, the potential of radiology, and the different modalities in diagnosis of the renal diseases. But at the same time, you need to be able to pick up few basics of image interpretation, which is important in nephrology exams as also as well as in clinical practice also. Thank you. So if there are any query, any question, or because this was a very broad topic, so I know we are not able to discuss any important area in more detail. So if there is any specific question on any particular modality or any particular diagnosis or imaging sign, then you can ask.
Can we have some questions either directly or in the chat box? None, otherwise then we can thank sir.
Okay. So if there are any questions, they can be mailed.
Sure,
Thank
sir.
you very
Surely,
much.
sir. Surely, sir. Thank you. And can we share this recording of this session with the students, sir?
Yes.
Thank you, sir. Thank you so much. Thank you for sparing your time.